Hello, I'm Dr. Betty Maloney, Education Co-Chair for Invisible International. At Invisible, our mission is to educate about the impact of tick and vector-borne diseases, which have worsened with climate change, ecosystem imbalances, and public health funding inadequacies. My talk covers the barriers that human clinicians experience when facing a patient with Lyme disease. These barriers further delay adequate treatment of patients and contribute to the burden of chronic illness. One Health is a problem-solving framework that strives to improve the health of all living things through collaborations between animal, plant, environmental, and human health experts. While we discuss the necessary improvements in communication between human and animal clinicians, and embrace a One Health model, we must also address the barriers that are unique to human clinicians, which once removed will contribute to improvements in patient care. I have no financial conflicts to disclose. This presentation discusses a paper I recently co-authored with Lorraine Johnson. It was published in the journal Healthcare. Before I discuss that paper, let's spend a minute reviewing the Lyme landscape. There are roughly 500,000 new cases of Lyme disease each year in the U.S., and we know from John Aucott's work that ideally treated patients presenting with an EM rash, meaning those who were diagnosed early and promptly treated with 21 days of doxycycline, had at the one-year endpoint 44% remain symptomatic at a moderate to severe level alone, or symptomatic and functionally impaired. In our paper, we defined persistent Lyme disease, chronic Lyme disease, or PLD-CLD, as those patients who are diagnosed with Lyme disease but who remain ill 6 or more months following antibiotic therapy. Allison DeLong and colleagues estimate that there are more than 2 million people in the United States with PLD-CLD, and as acute cases continue to escalate, we can expect that this will be a growing population. The patient perspective on PLD-CLD has been researched in the past. We know from surveys conducted by MyLyme that these patients have a significant disease burden. Many are disabled or had to cut back on employment or school activities. They experience problems accessing care. 78% had a delayed diagnosis. 49% drive more than 50 miles to see their treating clinicians. Out-of-pocket costs are high and in some instances prohibitive. But Lorraine and I were interested in taking a look at the Lyme landscape from the perspective of the treating clinician. This survey was conducted by LymeDisease.org and used the SurveyMonkey platform. It's the first to focus on clinicians treating PLD-CLD. The survey primarily asked multiple choice questions, but did include one open text question which allowed respondents to comment as they saw fit. There were 155 participants from 30 states. So who are these clinicians? As a group, they have wide clinical experience. 81% treat a variety of conditions and not exclusively Lyme disease, although 57% devote more than half of their practice time to the care of Lyme disease patients. They're well educated for their role. 98% have taken CME courses on tick-borne diseases. And more importantly, they've got lots of clinical experience. As this diagram demonstrates, 56% have treated 500 or more patients. 38% have treated more than 1,000 patients. Practice dynamics are notable. Their practices are full. 60% report that patients had to wait a month or more to be seen. 8% had waits of 4 or more months, and 4% of respondents are no longer able to accept new patients. In many practices, out-of-state patients are common. Initial diagnostic delays are common in this patient group. Several items on this list suggest that many clinicians are insufficiently knowledgeable about Lyme disease. And you can see 86% of the respondents said that clinicians needed more education on tick-borne diseases. Also, there's lots of misdiagnoses that patients have before arriving at a PLD-CLD treater. Many patients were denied a diagnosis because they lived in what's thought to be a low incidence state. Not surprisingly, clinicians report that their patients present with complex situations. Most are quite ill with multi-system disease. More than half of treating clinicians report that their patients have cognitive impairments, which adds another challenge to providing care. Everything from history taking to discussing post-visit plans takes longer. Memory impairments necessitate repeating information and the use of other memory aids. Due to the complexity of their situation and their cognitive impairments, these patients generate many between-visit phone calls to the office. There are structural barriers to providing care. Professional stigma is a powerful barrier. As described here by Nightblade, it can be broken into three concepts. Stigma is a powerful social process, characterized by labeling, stereotyping, and separation, leading to status loss and discrimination, all occurring in the context of power. This is how stigma plays out in the lives of PLD-CLD clinicians. 75% report that they've been stigmatized. 61% report a lack of collegial support. And notably, 11% were excluded from insurer networks. A very careful clinician that I know was doing very well with his PLD-CLD patients, but out of the blue got a letter from his insurer basically demanding that he treat according to CDC recommendations, and if he didn't, that they were going to kick him out of the network. Since the majority of his practice was not devoted to Lyme disease, he had to actually let go of his Lyme patients. Regulatory bodies are another structural barrier. 39% of the respondents had issues with one or more regulatory bodies. 19% were the subject of a medical board inquiry, and the related costs in time, money, and mental energy is substantial. Many had been reported to medical boards either by colleagues, patients, insurers, or anonymous reporters. 11% were reported to a third-party payer, similar to the physician I just described. Fewer were reported to hospital quality improvement committees, and perhaps this is because few survey participants had hospital privileges. The economic models available to clinicians make it financially challenging to provide care to PLD-CLD patients. The most common model in non-Lyme practices is insurance-based, where insurers reimburse for the work done. Unfortunately, the work required to care for PLD-CLD patients, the extended duration of the visits, and the heavy burden of completing numerous prior authorization forms and appealing insurance denials, means that the reimbursement offered by insurers is inadequate. The alternative model is patient-based. Unfortunately, many patients cannot afford out-of-pocket costs, which is a concern to many of the survey participants. Despite that, 74% of respondents reported that they operated on a cash basis only. And so we can think of professional stigma, regulatory investigations, and failed economic models as forming a wall that not only separates patients from clinicians, but also produces significant disincentives for clinicians to provide care. As depicted here, this leads to a significant supply and demand mismatch, which is why patients have trouble finding a treating clinician. Thankfully, there are ways to break through that wall. Important solutions include more robust clinician education programs, which should reduce treatment delays and therefore limit the patients who develop PLD-CLD. 2, reducing the burdens of stigmatization and regulatory investigations. And 3, promoting innovative reimbursement modules that fairly compensate clinicians for the care they provide. Thank you for your attention. My references are listed here.